First, I would like to thank the organizing committee for inviting me today as chairperson for this session, liver diseases. Second, I would like to congratulate all my dear colleagues in the Department of Clinical Pathology for the great effort they have done in the total innovation and automation of their laboratories, which I personally consider as a piece of art. I would like to present our first speaker in this session, which is Dr. Hans Giffler from the University of Utrecht, Siemens Healthcare Diagnostics.
Thank you for the nice introduction, Professor Mahmoud Saad. Also, thank you, Professor Abla Al-Said, for the nice invitation, and also Dr. Magdi Al-Hurdini, which I met recently in Abu Dhabi, and we talked about ALF in relation to hepatitis cirrhosis, and he invited me for this pathology meeting. How do I get my... So, just to give us, let's say, a short introduction, this project started with beta diagnostics 14 years ago at the University of Southampton in the UK, where Professor Arthur detected a non-invasive method with biomarkers for fibro detection in the liver. And at that point, he came to biodiagnostics with this idea to develop a serological test with biomarkers to detect the fibrogens in the liver. As you know, since 5 years, Siemens Healthcare has also been involved in the diagnostic area. And from there, Siemens took this project to the market. And last year in Berlin at the EASL, we launched this new project into the market. In the 40 minutes I see I have half an hour instead of the 40 minutes, so I have to do it quickly. I would like to go over the friction. Is biopsy the gold standard for the detection of fibrogenesis? Our ALF biomarker panel, and then how we have validated this panel versus the, let's say, so-called gold standard. The reason why Siemens took this project into their diagnostic area was because already we had serological assays available for the diagnosis with an automated serological system, the Centaur, where we would be able to detect if a person has hepatitis C, hepatitis B, or hepatitis A. Also with molecular diagnostics with bDNA, which is invented 30 years ago and is moving now to qPCR, we are able to detect the viral load. Then with also imaging, we are able to measure liver stiffness. With INO-LIPA, we are able to detect the genotype, and I've learned that in Egypt the major type is genotype 4A. And now, and that's the reason why I'm here today, is to talk about the ALF diagnosis, a non-invasive test for liver fibrosis. As you are aware, the liver is a very important organ. It's involved in the storage of nutrition. It's also the synthesis of clotting factors, regulation of cholesterol, glucose, but also the metabolism and detoxification of alcohol. Here you see the morphology of a normal liver cell. What's important to remind over here is that in the space of this, we have the so-called stellate cells. Stellate cells are in the area of this and are the storage cells for vitamin A. However, if you are challenging the stellate cell, there is a genotypical change into a fibroblast-producing cell, and that will cause the, let's say, the detection where our assays are detecting those biomarkers. If the trauma to the liver exists, for instance, due to hepatitis C infection, hepatitis B, or obese, then still, if you are in the early detection of the disease, there still is a regeneration possible, so a reversible reaction. So that's why the earlier you are able to detect who has the infection, you still can handle and change the patient management into the good direction. If you have a persistent injury by, for instance, hepatitis C, which is very endemic in this area in Egypt, you are developing fibrosis, but still if you are in an early detection of fibrosis, you could still go in the reverse area. The trajectory from fibrosis to liver failure and liver cirrhosis is around 20 to 15 years. So that is indeed time if you are detecting this early enough to regenerate. Here you see just the number of liver injuries which are involved, and for this area the hepatitis C are in this 550 million people who are suffering and getting the liver damage through the viral hepatitis. But in my area, I'm from the Netherlands, we still see more and more in Europe that the amount of obese patients is growing. Here you see the amount of 400 million patients. In 3 years from now, that will be double and close to 800 million people. It is a shame to say, but at this moment, more people are dying for overconsumption of food than underconsumption of food. And this is a tragedy. And the difficulty over here is that in 15% of the cases of obese patients, they are developing a serious liver fibrosis. But we do not know who are those 15%. So you have to follow up those patients. They have to change a lifestyle. But it's not nice to have, let's say, since liver biopsies are going down over the time, to go for it. And you want to have a non-invasive technology. You see, again, this is the normal picture of the liver diagnosis. Here you see already, if the liver is injured by those effects, you see already that the villi on the side where you have the exchange with the blood is more or less gone. You see as well that the stellate cells have, let's say, have a genochemical change into fibroblastic producing cells. And also you see that the epithelial layer over here, where you still have fenestrae over here, are closed. And this means that you have a higher portal venous pressure, and this is causing, of course, a bleeding potential if you are already in a longer stage, and you have varicose bleeding around the stomach and esophagus. You're probably familiar with the liver staging. Here you see the normal liver, liver inflammation, where you see already a fatty liver. But if you do not do anything, you see already fibrosis around the vessels, and you see that if you do not interfere by treatment, that you are ending up with cirrhosis, and if you do not do anything, you could end up with hepatocarcinoma. And the only thing left then is a liver transplantation. This looks like a complicated slide, but in principle it's not. You can divide the classification of liver disease histological, hemodynamic, and biological. I will spend a little bit of time now in, let's say, the histological typing of the chronic liver disease, because if you come with a new technology in the field, you always have to compare your technology with the gold standard, and still the gold standard is liver biopsy. Then also, if you look to the symptoms, because that's the other problem with hepatitis C, in a lot of cases it's asymptomatic, so you have to follow up. But if you are already ending in the compensated phase, or the decompensated, where you have ascites and sulfopathy, you're already ending a little bit late. So also around the hemodynamics, you will see, due to the closing of the fenestrae, an increase of the portal vein pressure. And of course, you are able to find scar tissue in the liver if you do not interfere in the early stage of the fibrosis. And here you see that because of the stage 3 decompensated liver, that you have a 20% possibility of dying if you have already starting to develop ascites, and if you have bleedings because there is cirrhosis in the liver, you get blood pressure over here, and you see that you are able to develop varices and varicose bleedings. So therefore you need to, let's say, already be very cautious and to do endoscopy as well, and maybe to tie in those varices for preventing bleedings as well. But you see the chance of dying is already close to 60% at that stage. So again, the earlier detecting the better. So the problem is when the liver fails, and you have seen how important the liver is since it's involved in almost all important processes in your body, you are developing ascites, and this is a picture of a Vietnamese lady who died soon after this picture because there was no liver available for her. And you see, transplantation at that point is the only option, but if a liver is available, because many are waiting for a transplantation. So again, this is a warning. The earlier we are able to detect the hepatitis C infection and follow up on liver fibrosis, the better. Now we come to the part of the laboratory technologies. As soon as the liver is injured, you will see that the ALT, the liver enzyme, the liver function enzymes are increasing, but still you do not know what is the causing damage. Is it hepatitis B, C? Is it alcoholic liver disease? Is it obese because of the, let's say, the food intake? So the next step is, and in the case of Egypt, of course, the first thing you would do is go for hepatitis C and hepatitis B serology to find out if there is an infection in this patient. The problem around fibrosis is that it's a very slow process, and from the moment you're using biopsy to detect, you only have a staging, so you could only go from stage 1 to stage 2, from 2 to 3, from 3 to 4, where it is a dynamic process. And when you are measuring biomarkers, you can follow this dynamic process much better than with biopsies. The other problem, if you do a biopsy, is that the cirrhosis is not completely at the same level divided into the liver, and you only are taking with the biopsy 1/50,000th part of the liver. Based on the biopsy, based on the length, based on the gout, you have a kind of, let's say, positive outcome, and that is, if you are having a good, let's say, function, if you have a good pathologist, the maximum sensitivity for, let's say, a biopsy is 75%, which is really not high. And that's why I come to the conclusion, and not only me, but also the literature, that biopsy is not the gold standard, but maybe a bronze standard. So, are we going to replace biopsies totally with fibromarkers? No, we aren't, because still you need biopsy for pathology, but you can use a non-invasive technology to rule in and rule out who are at risk for developing this fibrosis. And like I said as well, it's not the gold standard, because also it's very subjective. If you have pathologists A, B, or C, you give them the same biopsies and you ask them to use the Ishak staging, the new one from 0 to 6 or the modified one from 0 to 4. Still, it is very difficult to identify those individual groups. So it is what we call subjective. Like I said as well, you could have sampling errors, because it's not homogeneous developed in the liver. And the other part is, of course, it's an invasive technology, and I think the price in Egypt is probably lower than in Western Europe, but still, you need a doctor, you need a nurse, in some cases you need a hospital stay, you need a pathologist, so many more people are involved. So the costs are really much higher than a biomarker test. And like I said as well, a biopsy is just a snapshot in time of the development of this fibrosis. And if you would like to follow this fibrosis over time, you have to do multiple biopsies, and patients would not like to have all those biopsies. And also it's painful, it's bleeding, and it's in principle also the staging like you see over here, which you are looking at. And like I said, biopsies repeating is not an option. Also when you're going to follow treatments and you have to do follow-up on biopsies, still a non-invasive or a minimal invasive technology like a serology sample is much easier to do. This is what normally the pathologist will see under his microscope. Here you see the normal liver cell with the vena, the hepatica and the bile duct. Here you see already lymphocytes infiltration in between the normal liver pathology. Here with a special staining you will see already fibrosis, and here you see the hepatocellular carcinoma. And like I said, the process will take around 20 to 25 years. Staging was difficult. If I, let's say, put it here like those pictures, it seems to be easy. But here you see the F0 staging or the Metavir classification. This is how you call stage 1 if you have already some portal fibrosis without septate. But here you see the slight difference between stage 1 and 2, where you already have septa around the veins, but not yet the connecting ones. You see them over here, and already numerous septa. And then at the end stage you have the cirrhosis, where liver function is almost impossible. But you see the difference between those two and here are not really significant big. And that's also in taking account, you always have to mention which kind of staging you are using. Very often in, let's say, your Metavir and Ishak, or the modified Ishak, is used for classification. And here again you see the 0 to 4 classification and also some pictures. But if we look in, let's say, the classification stage, in principle there are only, based on the microscope, 3 groups that you really significant can differentiate. And this is what we have followed as well with our assay. And here you see the 3 different groups. So instead of talking about the F0 to F4 staging, we are talking about no to mild fibrosis, moderate fibrosis and severe fibrosis. And here you see the Ishak fibrosis score, the 3 to 4, which is to the moderate, and 5 to 6, where you have the severe fibrotic staging. And that's what we have done with the serology as well. We have also 3 meaningful groups. So this means if you want to discriminate those 3 meaningful groups, this cannot be done just by one cutoff setting. We need 2 cutoff settings, because we need to go here with a cutoff setting to get, let's say, as much as positives included, but we have to have a second cutoff, and I will have another slide as well, to guarantee the sensitivity. And again, we are focusing at a higher level than the sensitivity and the specificity than the liver biopsies. Again, this is my last slide showing about why biopsy is in principle not the gold standard. This is just one and the same liver slide of a diseased patient, and you see when a gastroenterologist or a hepatologist has taken a biopsy in this area of the liver, sent it to the pathology, the diagnosis would have been just an F1. So just some, let's say, fibrotic sepsis, but no, let's say, connecting one. On another part, on the same level, if you have taken a biopsy in that area, the pathologist would give the same patient an F2 staging. While if a pathologist would have taken a biopsy in this area when the liver was still in the patient, it would have been F4. So you see as well, besides the subjectivity of the microscopy by the pathologist, Still also, it depends how homogeneous the fibrosis is throughout the liver and where the biopsy has been taken. And here as well, additionally, you will see that the length of the biopsy even make, let's say, a part of your correct diagnosis. And if you have a 2.5 centimeter length biopsy, you will reach that 75% sensitivity outcome. You have to remember that 75% outcome. Because now we are moving away from the gold standard biopsy, where our technology still have to refer to this biopsy technology. So that's the reason why, and this is published in many literature, that liver biopsy is not the gold, but a brownish-brown standard. And I hope I have explained in my last slides why this is not in principle a very gold standard. Other technologies than liver biopsy, CT and MRT, ultrasound, but today I'm only going to talk about the fibromarkers of the specific markers of fibrogenesis. Before we knew where to go with fibrogenesis biomarkers, this looks complicated, but I will go a little bit with you through this. When we started with Professor Arthur 12 years ago at the University of Southampton, we had no idea which of the markers we needed to use. So we used them all in the beginning. And here you see some examples. Here you see the stellate cells. If the stellate cells are triggered, you see that they are producing tissue inhibitor metalonic proteinase. It's easier to pronounce it like TIM1, and I will do this with the lecture as well. It stimulates extracellular synthesis of fibrin, where it inhibits the degradation metalloproteinase enzymes, which normally are degrading this extracellular matrix. So by understanding those models of fibrogenesis, we were able to define which of the biomarkers we needed to go for. And you have to remember those are specific biomarkers involved in fibrogenesis, not the liver function tests. Because you are already aware that within the lab you do your liver function test. Nice, because they're very early, you know there is something happening with the liver, but you do not know what is causing this increase of your liver function test. Still, you have the possibility to go for platelet counts or for cholesterol, haptoglobin, where you also can detect the liver failure. But you see, this is a little bit late. And in the beginning, I talked already, the earlier we are able to detect the fibrosis, still, and also the hepatitis C infection, we could treat this and we could reverse. And also, when I go back to this previous slide, there are young startup companies busy to make pharmaceutical blockade treatments available in animal models already to block the stimulation of this synthesis. So besides only to go for a treatment on hepatitis C, also they are looking into treatments of fibrogenesis stimulation in an early stage. But those are not the real markers, but because they have poor prognostic outcome, and this one is poor. Why? Because it's already at the end stage of fibrogenesis. So that's why we were looking into this field of the direct biomarkers related to fibrogenesis. And when we started 12 years ago, we included all those markers in our studies, and finally we found out that we needed 3 of those biomarkers in certain paradigm calculation to have an outcome of fibrogenesis. And that is the combination of hyaluronic acid, procalogane 3-amino terminal peptide, which is in the shortcut P3MP, and tissue inhibitor of matrix metalloproteinase, which is TIMP1. If you test those three out of a serum sample of a patient and they are put in a matrix for calculation, you get a risk index factor for liver injury of, let's say, liver fibrosis. So in principle, this is an animation just to show if you have those specific biomarkers secreted by the liver, you see they are going into the bloodstream, and then because when you take a phlebotomist a sample, and based on testing the serum sample, in an hour you will know at which level of fibrosis the liver is staged. You could run this on our system, which is called a Centaur XP or Centaur CP, which is a tabletop model. We deliver all the reagents, and this is a very important difference between another test which is available from France, the Fibro test or Fibrometre. We are delivering to you the full 3 parameters, the calibration, but also the quality control. And that is the difference, and we just had a nice chat before I started the lecture about, there is no control with Fibrotest and Fibrometre about the quality control. Here, everything is in the kit itself. You see it's a 50 test kit. It's just you need a small sample size, 20 microliters, 20 and 25, in addition the dead volume of the system, so 200 microliters of sample. And in 1 hour time, you get a result within your laboratory, directly calculated, and this is the ready-to-use calibration and control set, which we have provided as well. And here you see the result. The results are given per hyaluronic acid B3MP and TIMP1 in nanograms per ml, and this is the calculation, the metric factor, which is what we call the ELF score. Here you see the natural log of the concentration of hyaluronic acid and the natural log of the concentration of P3MP, and the same of TIMP1. It took us 12 years to find this out. The problem of this 12 years is, or the positive outcome of those 12 years is, that you already have literature available that the proven outcome has worked. How did we find this? This is the first study published where 921 chronic liver disease patients were tested in the UK, where we had serum and biopsies longitudinal over time. And like I said, we have to work with 2 cutoff values, because we need to include as many patients who are at risk for fibrosis, and we placed our lower cutoff at the 19th percentile sensitivity. So that means that's even higher than the liver biopsy, because that was 75%. But you see, if you put it over here as well, you get too many as well patients who are in the middle of, and you do not know where the disease is. So also we have a higher level cutoff to show that there is a high level of specificity. And based on those 2 levels, again, you see the 3 patient groups are coming here together. Like I said, equally to the biopsy. You have the group none to mild, the moderate group, and the severe group. And here you see the ELF score outcome that correlates with the disease state. If the ELF score is smaller than 7.7, you have no to mild fibrosis, so you do not have to interfere. If you have ELF score bigger than or equal to 9.8, you have a really severe fibrosis already, and you have to change your patient management. If you are in the middle, we call this moderate. And the positive thing of the moderate is that if you would have a moderate zone with your biopsy, you have to request to come your patient back half a year or a year later and do additional biopsies. By using a serology assay, you already have this score at 0.0, patient comes back, if you want to let it come back because it has additional failures in liver enzymes and it's a hepatitis C patient, you know that half a year later, if you have not treated this patient, your ELF score could go up without doing the biopsy. So you have really a kind of dynamic measurement of liver fibrosis available. And here you see one publication that shows that you could avoid already 45% of your biopsies, but it's depending, of course, where you have your cutoff value. And in the beginning, in 2004, this publication, we had only one cutoff. Which kind of applications have we tested for this ELF already? Because every disease management, we have to test it individually. So, of course, we have tested our ELF liver fibrosis for hepatitis C patients. Very important for the Egyptian, where you see as well that the area under the receive curve had an excellent outcome versus biopsy. Here you see a publication where we could already avoid 81% of the stage above 9.8 and 63% under the 7.7. In total, we could
1 minute remaining.
68.6% of the biopsies. This has led to an implication that also in the diagnostic algorithm for the EASL guidelines, last year they implemented the non-invasive biomarker test in testing of the fibro test, in testing of the fibrogenesis of the liver marker. So this is a big achievement, so it's really already there. Like I said in the beginning as well, this ELF testing could also be used for obese patients. I told you that 15 to 20% of obese patients are moving in a serious liver fibrosis. But you do not know which of those 15 to 20% is moving in that direction. By testing this with the ELF diagnosis without any biopsy, you know who of the obese patients are at risk.
Your time is up.
We have published this. Maybe another. Yeah. We have published this already for adults. We have published this as well for children. And at this moment in King's College in London, they get rid of the biopsy already for obese patients and include ELF testing for those patient groups. And here you see the outcome as well as a predictive value. The prognostic of the disease is really very important. And I think this is one of the best studies we have to show that ELF could better diagnose the disease-related outcome and mortality much earlier than biopsy. Here you see the Kaplan-Meier survival curve, and again the three different groups if you use the biopsy, the no to mild biopsies, the moderate outcome, and the severe group. When you start at time point 0 to include all those patients, you follow them over time, you see that patients are passing away. And we always look to the median survival curve, which is where you have lost 50% of your population included. And you see that for biopsy, this disease-related outcome of mortality related to liver disease was somewhere between 6 and 7 years. We studied the same population of which those biopsies were getting with serology. And again, you see here the differentiation of group 1, mild to none, moderate, and here you see the severe group. And if you look to the same median survival point, then already, just after 2 years, we could prove that the disease-related outcome of the mortality had to do with liver disease. So this means, if you have a high score with the ELF, you better immediately have to change your disease management of your patient, because you know the chance is huge that this patient will die based on a liver disease. So here, I think this is the best proof to show to you that liver biopsy is in principle not the gold standard for the detection of fibrosis. And based on this outcome, the university also in Southampton made their patient management style different. If a patient on serology has an outcome of bigger than 12, they immediately do alpha fertiloprotein to see if there is already a carcinoma there, an ultrasound scan, and also an index endoscopy to see whether or not this patient is at huge risk and should be put on the transplantation list. Also, the follow-up of, because I said as well when I showed that complicated slide of fibrogenesis, if you want to treat or block the fibrogenesis at any point with pharmaceutical media, you have to also follow up the treatment of this patient. And again, you do not want to run into biopsy for this follow-up, so you want to use the same technology. And here you see a publication where you have severe responders, where you see the decrease in the concentration of P3 and P. Also, TIMP1 is decreasing, and a little bit less for hyaluronic acid. So also this assay makes it available for you to follow up the fibrogenesis treatment in patients versus, let's say, again and again doing a biopsy. Here you see as well different technologies follow up, but because of the time that it's also this is the ELF testing, knocking out all the others, and here as well versus the hemodynamic of an increased pressure. And here, like I said as well, you can use this if you have your measurement of your ELF at time 0. The patient comes back over time. You see that this patient is not changing as well, so it keeps stable. Where you see here you have a moderate patient. If you follow this one in time, you see that there is a progression of the disease. And here you see one, let's say, potential patient, which already was in that area and potentially hepatitis C, or lifestyle changement, or the treatment of hepatitis C. So you see that you can follow the ELF score over time. This is my last slide. I hope I have shown you that there is a good correlation with the so-called gold standard, the biopsy. We have validated the ELF technology for, and ELF stands for Enhanced Liver Fibrosis Test. We changed the name a little bit because originally when Professor Arthur started in 1998, he called it European liver fibrosis because he worked with 13 centers in Europe to collect all valuable samples and biopsies together. And we changed, we kept the name ELF, but we changed it a little bit. You also have seen that we have validated it for hepatitis C. Publications are available for obese patients and also for alcoholic liver disease. Last week I was in Sweden and Oslo. There the fibrosis and liver fat, and also in Russia and the UK, predominantly is alcohol liver abuse. So also here a lifestyle change could prevent this, let's say, cohort from getting this fibrosis. And of course, we continue with our clinical studies, and tomorrow I will be at the University of Cairo to discuss a multi-center study with Professor Gamal. Sorry to go a little bit over time because I thought I got 40 minutes, and I hope I didn't disturb your lunch or coffee break. I do not know if there are any questions because I'm still here.
Can we leave the questions after this second session?
Yes, of course. Thank you.
Thank you for your valuable talk. And I think, sorry for the audience, it's a little bit longer, but fibrosis is an interesting subject for our country. So we move.
May I call on our next speaker, Professor Rehan Kemal. Our distinguished guest is Professor of Hepatic Surgery at Ain Shams University, and of course we all know that he is the pioneer of liver transplantation surgery in Egypt.
Mrs. and Mr. Chairman, thank you very much for your kind presentation. I'm very pleased to be here in Alexandria University. I have so many friends. I would like to thank the Department of Pathology for inviting me. And I know this is not a surgical meeting, so I'll not go through a lot of surgical details. And I'd like to thank my friend, Professor Dr. Mohammed Assawi, for his kind invitation as well. I will present a very short presentation, our experience with living women and transplant. We started our program in 2001 with the first well-structured LDLT program. And when I say well-structured, because there were many attempts before, but not as part of a truly well-structured program. And it's very important in a transplant to have various teams involved. We have about 18 subspecialties involved. And if these groups don't work together properly, you end up having catastrophes. So it's very important to have a well-structured program and respect to all the different specialties involved. In September 2007, we launched an additional national transplant program in the first public sector hospital. And we have performed more than 400 cases of LDLT in both programs. Now we have reached 450. The first 400 cases were mostly adult. Our program is mainly an adult program with 395 cases adults and 3 pediatrics and 2 retransplants. The adults were mostly right lobe, and I will explain soon why they were all right lobe grafts. And the 3 pediatric, 2 were left lateral, and 1 again was right lobe. As you very well know, numbers are not everything, but patient outcome and donor safety in this context of living donor liver transplant is of extreme importance. Ethics of transplantation is a very important issue. A huge breach of the ethics in the field of kidney transplantation has been happening for years, and we're all aware of. This awareness stimulated us to start LDLT from a different platform and aiming at a very ethical practice as much as possible. 2 independent ethical committees were established in each program, one in the hospital and the other in the syndicate, and now in the Ministry of Health. We followed and we worked on issuing the Istanbul Declaration along with a lot of other members from different countries. And the Istanbul Declaration is a guideline for the proper ethical transplantation and what to do and not to take fake donors, etc. And now with the new law which we have helped to pass in 2010, regulation is tighter and only through the Ministry of Health. And any transplant program now has to be accredited from the Ministry of Health, from the High Supreme Council of Organ Transplantation, and you have to present your results every year, and there are committees coming to check these transplant centers, and you can lose your license if you don't do things the proper way. As far as donor selection, donor safety is of utmost concern and of utmost importance. We do ABO compatible but not identical patients and donors. They should be related for ethical considerations. However, the law allows up to the 4th degree relatives. They should be healthy and aged between 21 and 50 years and a BMI of less than 28, and a higher BMI results in a higher risk of surgery. That's why we aim at a BMI of less than 28. A GRWR, which is the graft recipient weight ratio, which is the ratio of the graft that the patient receives, should be around 1. So if you have a patient of 80 kilograms, he should receive about 800 grams of liver, and I will show why in a little while. The residual liver, or the amount of liver that you leave in the donor should not be less than 35% of the original weight of the liver. We avoid trifurcated portal, which is a special anomaly because there's a higher incidence of biliary complications. And I will tell you why, because the biliary complications have been our main concern in our transplant program and in various transplant programs around the world. We do a preoperative MRCP to select donors with single ducts, maximum 2. All schistosomiasis, which is a problem that we have quite commonly in Egypt, is acceptable as long as we have a rectal stick which is negative and shows dead over an ultrasound of the liver which shows a normal liver. So the old schisto could appear in the lab results, but only in the lab results. Up to 10% steatosis is acceptable in the liver, and it should be subtracted from volumes with readjustment. We do a routine biopsy. We didn't start our program by doing routine biopsies. I know my previous speaker spoke about biopsies, but in cases of living donor liver transplant, it's a bit different because we need to do a donor biopsy. Initially, we started not doing donor biopsies in the donors, and then we opened one donor, and in spite of all investigations preoperatively, we found schistosomiasis that was not diagnosed preoperatively, and he had bilharzia liver fibrosis, so we aborted this operation. And since then, we changed our practice and we started doing biopsies routinely. And why do we do biopsies routinely? Because if you see here, our results of biopsies from 2003, 2006, in spite of everything being normal, about 30% of the biopsies showed some abnormal finding that could not be explained. It's not, of course, the typical cirrhosis or fibrosis, but some abnormal finding, like increased eosinophilia or abnormal pattern. And of course, any donor with abnormal pattern or suspicious biopsy is rejected from donation. We don't take any risks with donor. And you can see that the incidence is about 30%. It's not little. To understand living donor liver transplant, you have to understand that we give only part of a liver, not the whole liver like is done in Europe. And so far, we don't do cadaveric organ transplantation. We do only living related, so we take part of a liver. When you give half a liver to a patient, you have to choose simply better patients because the right lobe grafts are incomplete grafts and they are compromised by nature. So at the end of the day, you cannot just transfer the experience of Europe and the States that do cadaverics to the Egyptian context. And you should choose the right combination of graft, recipient, disease, and technique to achieve the success of surgery that is needed. Every time we have reached this law and we have exceeded the limits, we have had a mortality. Partial grafts are compromised grafts. Yes, and this can be shown here simply. The MELD score is a score to score the severity of the disease. And it includes the INR, the bilirubin, and the creatinine. And if you have a patient with a high MELD of 25, you have the red line with a high mortality. Your best patients are between 18 and 25 MELD score, and of course less than 18, you have good results. And why does this happen? Because the highest mortality is within the first 90 days, until the liver regenerates. When the liver regenerates, it can take the burden of the disease. But originally, it's a small liver, so it cannot take a very sick patient. And once it regenerates, the mortality goes down dramatically. So your best bet is a MELD score or a severity score between 18 and 25. Again, why do we take a GRWR or a graft volume of about 1%? Because with a 1% volume, you have a success rate of about 92%. If you go down to below 0.8%, your success rate goes down to 60%. So it's better to give your patient a good volume of liver. The MELD score here in the American series again shows that most cases of LDLT are done for the MELD between 6 and 20. And if you go higher, the MELD score is, the number of cases that are done with living donor are much less. Now, our results, we've done, these are the 400 cases. The average age has been 30 years. The sex, 21% females and 79% males, and I just tell to all the doctors around here that we have had a lot of women donating men, but no men donating women. We've had a survival of 100%, and we've had a mortality of 0%. A donor mortality is catastrophic, but unfortunately it does happen around the world, and there are about 30 or 40 donor mortalities around the world. Donor complications, we've had no donor mortality. However, we've had complications, and there is a specific way of classifying complications in donors, which is the Clavian classification. Our complications, which were Clavian 1 and 2, we've had myeloma, we've had aborted operation I talked about, we've had portal vein thrombosis that required surgical re-exploration and thrombectomy and anticoagulation post-op. So donor complications are to be avoided as much as possible by proper preparation, and that's what we try to do all the time. Recipients, we've done 400 cases. The average age was 44. The sex, 5% females, 95% males. The male, our average male was 21. Our child, 79% C, 11% B, and 10% A. You would tell me, why did you transplant child A patients? Those child A patients all had hepatocellular carcinomas. BMI of about 26. Our age distribution, of course, was between 40 and 60 years of age. We've done all various ages, but that's the age where you see the brunt of hepatitis C and the brunt of the liver disease. And the decompensation, our sex distribution, as I have said, 5% females and 95% males. Our main indication for LDLT has been hepatitis C. We've done combinations of B and Cs, B alone. B, of course, is much more costly because you have to give those patients intraoperatively as well as postoperatively. You have to give them hepatitis B immunoglobulin, and they have to receive hepatitis B immunoglobulin at least for 2 to 5 years post-transplant, and maybe lifetime even. So the cost is dramatically more. However, B is a curable disease, while C, there is an incidence of recurrence. We've done the biliary atresia, we've done Wilson's disease, we've done graft failures, and this was a retransplant and cryptogenic cirrhosis. HCC, we've had 77 cases with a lower MELD score, as I just explained, and 72 were within the Milan criteria. And simply the Milan criteria are either you have a single tumor of less than 5 centimeters or 3 tumors, each less than 3 centimeters. However, although the Milan criteria were our standard way of doing things until quite recently, now we go for the up to 7 criteria, and the up to 7 criteria basically are if you have the size of the tumor plus the number of the tumors, they should be 7. So you have a tumor of 6 centimeters and 1 tumor, then 6 plus 1 equals 7, or 2 tumors, and the largest one would be 5, so 2 plus 5 equals 7, and so on. And this is one thing about HCC that I would like to mention. The other thing I would like to mention about HCC is that you can downstage your patients with interventional radiology, whether chemoembolization or radiofrequency or a combination of both, or even sometimes surgical resection, and then you could get them into the Milan criteria or the up to 7 criteria and then transplant them. But if you do that, you have to give a period of 3 and sometimes up to 6 months of observation for the patient to make sure that there is no spread of the disease beyond the liver, and then you can go for the transplant. Our mortality in relation to age, the highest mortality has been in the above 60, and this is quite understandable, but our age limit is 65. We've done 67 and 68 also. We needed to study the causes of mortality, and this brings me to the next part of my presentation. I won't take too long. And when we studied the first 130 cases, we found that, of course, you had post-operative bleeding, etc., but the most important was the biliary complications. We have had a problem with biliary complications, and this is the big challenge of transplant programs around the world, and it is known as the tender Achilles of transplantation. So we studied, and we found that we had 6 mortalities.
1 minute remaining.
6 mortalities due to biliary complications, and I will go back to this. We've had, like I said, other factors influencing the survival, like latent infectious complications, extrahepatic organ dysfunction, surgical complications, and a prolonged cold ischemia time or a prolonged warm ischemia time. And the warm ischemia time is the time that you take to put the new liver in, and the cold ischemia time is the time when the liver is kept in the cold, in the ice, moving from one room to the other until the patient is ready to receive the transplant. And we try to keep those to the minimum. And as I've said, we aim at a GRWR of 1. Like I've said earlier, these are some of the indications of surgical re-explorations. If you go through the list, you will find that, again, biliary keeps coming, biliary peritonitis, biliary collections, etc. Of course, we've had the thrombosed arteries and so on, but we've dealt with those.
Your time is up.
But the biliary problems have been our challenge. What have we done to do this? And we have done really, this is a liver tear. What we have done, I will go very quickly through our biliary complications. We have managed to reduce our biliary complications from about 40% to 15%. And why do biliary complications happen? First, they happen because the grafts can have many ducts, like 3, 4 ducts sometimes. And this, of course, you have to anastomose many ducts, and this increases the incidence of complications, definitely. Also, you have arterial hypoperfusion, and the third thing is sometimes you can have a poor duct supply to the donor duct. And this is the graph I showed with the mortality from the biliary complications. And again, the morbidity, which was quite high in the first year, up to 70% in relation to biliary complications. And this is a biliary abscess, and these are biliary strictures. What we've done is we've modified a lot of things. First, we have changed our way we manage the biliary complications altogether. For example, ERCP is useful for diagnosis and treatment of most LDLT-related biliary complications and should be attempted prior to more invasive interventions. This we admit. However, in strictures, delay in operative intervention results in irreversible loss of the graft. So what we do now, we try to control our endoscopies not to keep on doing endoscopies forever until the graft is lost. So we give the patient one, twice, an attempt, and if it doesn't work, we go for biliary reconstruction. Of course, this has happened through our increased confidence in doing proper biliary reconstructions post-transplant. Cases of leakage, again, repeated drainage by PTE and so on, is acceptable, but at the end of the day, if you keep on doing this, you will end in overwhelming sepsis in the patient, and you will lose the patient. So the interventions, whether it be by ERCP or by drainage for biliary peritonitis, should be limited, and then you should go for a more active way of dealing with the complication to avoid losing either the patient or the graft. And the other thing that we have modified and that has made a hell of a difference is the technical solution. And we are selecting the donor anatomy preoperatively by MRCP, and we try and have donors with 1, 2 ducts maximum. If you have a donor with 3 and 4 ducts, then you try either to avoid it or to take the left lobe, and if you're obliged to take him because there's no other donor, then you take him, and after getting the graft out, we close the small ducts. And I end up doing 1 or 2 anastomoses at the maximum. And we have learned that by closing 1 or 2 of the small ducts, you don't do any damage to the graft. These ducts will be closed, and this part of the liver will atrophy, and there won't be any infection or problems. We do routine stenting with interrupted 6-hole proline stitches, and if separate ducts, we use separate anastomoses, and we always check the anastomosis at the end of leakage. And these have been our results in the last 400 cases, with a complication rate of about 15% and no mortality from biliary complications. So this has really dramatically changed the results. And I would conclude by saying Egypt has entered the era of liver transplantation in a grand way. There is a high preponderance of liver diseases in Egypt, which promises to make it a prolific center. Enthusiasm is giving way to regulation and control. And financial sustainability in public hospitals, which is our concern in university hospitals and different public hospitals, has been addressed by initiation of fundraising. And a successful LDLT program should not withhold the efforts to start cadaveric liver transplantation. And I end up with this slide. This is a patient and his donor, and these are the true heroes of the surgery. And I put the picture of the Sphinx, and I always like to say that we were the first to do transplants in the world, and we transplanted the head of a human being in the body of a lion. Thank you.
Thank you very much, Professor Kendall, for your very interesting, comprehensive, and at the same time concise presentation. Thanks a lot. And I think it's quite breathtaking, the magnitude of the work that you and your team have been undertaking. Thank you very much. I think the floor is now open for discussion and questions. Yes, Dr. Rania?
I'd like to ask Dr. Hans, please. You have mentioned that the scoring for the ELF is less than 7 for the none and the mild. Number one, don't you think we should have a cutoff for between the none and the mild? You have mentioned again that compared your study with the gold standard, the liver biopsy. I think the active fiber test gives us F0, which indicates that there is no fibrosis. I think we need more clarification in this point. Thank you.
Good question. There's, like I said, normally you have one cutoff between diseased and non-diseased. But we have seen, based on the biopsy, but also the biomarkers, that we found 3 bits of, let's say, patients. And this is a statistical analysis which had been done, that at the first cutoff you said, okay, we want to have 90% negative predictive value. At let's say you want to have everybody as much included, which is the 90%. The 90% which you include is already higher than the 75% with biopsy. However, you're seeing, if you do that, the 90%, then still you are losing specificity. So therefore you need the second higher level cutoff to, let's say, because I said we roll in and roll out biopsies. So if you are smaller than 7, you know that you are not at risk, or let's say that's only 10% because you have the 90% sensitivity, that you still would have fibrosis. If you go to the other side, if you have the 90% specificity, then you know that everybody, let's say over 9.8, has a serious fibrosis. So also, you do not include them in a biopsy, besides if you go for transplantation, of course, because I said we do not substitute biopsy in all cases, and this is one good example. So that's the reason, and therefore it's a good question. We end up, we did also blood donor screening with approximately 45% which end up in that moderate zone. And what do you do with the people who are in that moderate zone? You look to the additional testing. Is the liver function test totally different? Do you have a hepatitis C outcome with symptomatic? Then still you say, okay, this patient is at risk, so still with a moderate score, I go for biopsy. But it is to exclude the ones above and under. Yeah. And you call it a gray zone. Okay, we understand each other. I do not like gray zone, but still, you're right. Those are moderate, and you do not know whether or not they are prognosis in the bad direction or in the, let's say, the good direction. And that's why, based on the other outcomes and let's say the clinic of the patient, you still need to take a decision to go for biopsy, yes or no, based on the clinic. Yeah? Yeah. Yeah, that's correct, and that is why we have set it at 90%. But you have to remember again, we have done this against the biopsy, which was only 75%. So we give you 50% more, and to be, let's say, clear, we never have a 100% guarantee in life. Even when I started to work with molecular biology 20 years ago, I thought molecular would always give me a 100% outcome. Also not the case. So we have set those cutoffs in relation to biopsy, which is, let's say, so far the accepted technology, but even higher at 1990. But you are right.
Indirect biomarkers, not in the active test and Fabry test. Okay, we depend upon indirect biomarkers or markers, yes. But you here in ELF test, I think you depend mainly on the direct markers for the liver fibrosis, and this is the difference in between.
That's the difference. Although we have done, of course, there are publications available where ELF, of course, is evaluated against fibro test, fibrometer, RV, trans-elastography, and one of the last slides I showed you APRI and Forn score. And then you see in certain levels that we could be equal, but in certain levels we are better, because we are, just like you said, the specific biomarkers. Yeah. You use the panel of the 3 markers, although also, but that's different now for obese. Professor Rosenberg in the UK is looking now for obese patients to look for an algorithm, maybe to use only one assay, which is P3 and P. If P3 and P is totally different, then you go for obese patients for the panel. But for hepatitis C, you go directly for the panel. I will go back. This lady was right. Okay.
Thank you for the lecture. I have 3 questions. First, is it FDA approved? The ELF test is FDA approved. The second one, have you done a correlation study with fibro test, acti test? The third one, is it applicable or any model of Centaur? The third, is it applicable, the ELF test, on any model of Centaur?
Yeah,
Centaur,
okay.
of Europe?
Okay. First question, no. We have not yet a CE mark approval. And the reason for that is that we needed to go for more biopsies. And that's the reason why tomorrow I am with Professor Gamal. We have a CE mark approval. So I think also Egypt will follow the CE mark rules. And we get that a year ago. Second question was on the Centaur. It's applicable on every Centaur. But I have to say one question mark. The software included in the system will be supported only by the, let's say, the newer versions. So the first Centaur XP has no dynamic calculation in the system, but you see we have the formula, so we can put it in the list, or you can have it in an Excel file. But with all, let's say, the latest and let's say after, I think, 2000, we have to look at the serial number, it will be supported. But you can run the assay on any of the systems. It's only the software of the oldest systems will not support that, but still you get the results. And then we will provide you the calculation in the LIS so that you still are able to do it. And then the third question... Correlation, yes. The correlation studies are available, and ask your Siemens representative in Egypt. If they cannot find it, they come to me, and we will provide them because you are their customer, and I will somewhere else tomorrow. Thank you. Nice questions. There was a lady waiting there as well. I will get back to you.
Is there another conditions rather than liver fibrosis that can affect these markers and affect the interfere with the test?
Good question. I have seen in young growing people that it might, especially in the moderate zone, yes. I also got a question versus, let's say, a heart attack, because you have fibrosis as well. But here, the influence, and you have seen, it's the logarithmic concentration of hyaluronic acid, P3MP, and TIM. The liver is around 1.6 kilogram, let's say in average. The heart is very small. So the impact of that fibrosis on the liver is not that huge. I hope this answered your question. It was not.
Okay, thanks a lot for your talk. It represents the scope of all of us. That's why we are all eager to learn more about it. I'd like to ask you two questions. First, about the calculation of ELF score. Does it consider age, gender, or body mass index? That's the first question. The second, about its validity in other causes of liver fibrosis. You have mentioned about HCV, alcohol, and non-alcoholic fatty hepatitis. What about mixed forms of hepatitis, HCV, hepatitis B, or HCV, HIV? Also, what about metabolic liver diseases or autoimmune liver diseases? Thanks a lot.
Thank you for the compliment. It is a pleasure for me to be here and to be invited on this congress. The last question is, you've seen in my last slide, studies are still ongoing, because you mentioned a good one, the co-infections between HIV and hepatitis B. In Russia, this is very endemic, so we have a study over there. So we will see results of this one as well. In Poland, we are doing, and in the UK, alcoholic liver disease. We have already done biliary cirrhosis. So I showed already what we have in publications. That's hepatitis C, B, some alcoholic liver disease, but not big data. And we have a lot in obese and also in mixed populations. Now, also in the UK, we are looking into, can we, let's say, a normal GP setting, but you have to remind, of course, the hepatitis C prevalence is very low, based on, let's say, the differentiation of ALT, to enroll those patients, if they have an overweight of bigger than 25 BMI, or if they are obese, bigger than 30, then enroll them in the ELF protocol. That study is already ongoing in the UK, because in the UK 24% of patients are obese. Yeah, different. Genotype 4, yeah. That might be, that's based on genotyping, that might be interesting as well. Yeah, I will make a note of that one, and like I said, tomorrow we are in Cairo, where we also will have a study versus biopsy and also ELF. And since those are Egyptian serum samples, and your, let's say, serotype in 90% of the cases equal, we will see. But you see, we are 1 year in the market with this, and you are correct that you have to look at those genotypes. The other part is as well, your positive predictive value will be different if your disease state is going down. However, here, your disease state is, the first study I showed you, the prevalence was 33%. So for the mixed liver disease. But based on your, let's say, population and chronic liver disease over here, I understood between 8 and 10 million out of 18 million are having this. So you see, also you have to look to the let's say, the prevalence. That's a good question as well. That was your first question? Yeah. Like I said in the beginning, we started with 9 markers. We also included the age. So until 3 years ago, we had the 3 markers, including the age, no gender. But we skipped later when we looked at the statistical outcome, that if we could skip the age, there was no difference. And this is the benefit, I think, versus, because for you as people working in this field, it is easier just to put the serum sample on the machine. It runs it, it gets the score, you validate it instead of bringing all the gender into the same score as well. So the answer is yes, in the beginning we only had in the calculation, so if you go back to publications of 2006, you will see the old ELF calculation, including the age, but today, with the product in the market, nothing is included, so just the 3 markers.
I think we have time for only one further question.
I see a gentleman waving. That we have to discuss that with.
Thank you very much.
Sorry. Because the gentleman was waving, can we have one as last one?
We are much behind schedule, so.
Okay, just half minute. In our practice, we always want to differentiate between mesenchymal damage and parenchymal damage in liver diseases. Sometimes we have extensive fibrosis with good parenchymal compensation, which is good. But on the opposite, we have some sort of fibrosis with marked parenchymal damage. Can LF test differentiate between parenchymal damage and mesenchymal damage of fibrosis? Yeah, but we want to differentiate between parenchymal hepatocyte damage and mesenchymal damage, which is important. Can LF test differentiate that or not?
I have no idea because I do not understand the question totally well.
In Vibro and active test, we have grading and staging of disease. So grading can assess the activity of the parenchyma and staging for fibrosis. Is it available and applicable for the LF or not?
No, only for fibrosis.
Yeah. Thank you very much.
I think we have to end now. Perhaps we can continue the discussion over the break. The break will be only for 15 minutes. And I would like to thank very much Dr. Abler and Professor Kamel for their very nice presentations. Thank you.